So I'll stop talking at the level of generality now, and I'll talk with you a bit about the Counties Manakau experience between 2002 and 2010. Now, why am I going back in time? There are a number of reasons for that. One is to give you some sense of an evolution of a broad-based integrated care program. In other words, how it started and where it got to over 8 years. Secondly, this coincides with when I worked there, so I can give you some personal view of that. I'll talk about some of the key aspects of that work and the impacts that were achieved, and I'll also update the story with where things have got to since 2010. So this is a story about a very deliberate, planned and structured effort to manage growth and acute demand inside one district health board in New Zealand. So Counties Manakau in 2002, for those of you who've never been to Auckland, Counties Manakau is the poor part of Auckland to the south. It's where the airport is if you fly in. So in 2002, it had a population of just over 400,000. That population is now up to 515,000, which gives you some sense of the rate of growth. So 8,000 to 10,000 people a year. It's very high deprivation, very high Maori and Pacific population, and increasing Asian population. It's where all the refugees end up living. At 2002, it really had a health profile of a third world country. It had a hospital-dominated health system, poorly developed primary care, a hospitalisation rate growing at 8% per year, which is a bit frightening. A med-surg admission rate 24% higher than the New Zealand average, and 21% of acute admissions were deemed avoidable. It also happened that we were running a $48 million deficit out of a budget of about $850 million. So this is a picture of a burning platform, if ever there was one. One of the things about the DHB model, which creates a bit of a context for this, not only were we responsible for that budget, which was across the whole of the system inside Counties Manakau, primary care and hospital, and aged care. But we were also accountable for access and outcomes and inequalities, which is something that I don't think LHDs are actually responsible for. Bit of a frightening thing when you look at that sort of profile. But one of the great things that this happened to coincide with was the start of the New Zealand primary healthcare strategy. So the timing was fortuitous because this coincided with the introduction of primary health organisations, of population enrolment, and of capitation and new funding streams coming into primary care. So that was the one positive note in all of this. There was a second positive note, is that historically Counties Manakau had been underfunded against the population-based funding formula. So we could be reasonably confident that there was new money going to come into the system, not only because of the sort of population growth we had, but because we were going to be moved to equity over about a 5-year period. So the stars were aligning in terms of doing something about this pretty frightening situation. And when we looked at health status in Counties Manakau, this was a bit of a profile of what was going on. A profile of a third world country, as I said, and the most important bullet point on that slide is the last one. In other words, the hospital actually touched a very small number of people, whereas general practice touched pretty much everybody. So if we were going to direct our energies to having an impact on this, it wasn't about the hospital. It was about trying to get better value out of encounters at the primary care level. So out of some pretty detailed analytical work, we identified that our focus had to be on long-term conditions or chronic conditions. Health was essentially about high deprivation and inequalities. Maori and Pacific did much, much, much worse than the rest of the population. So there was an 8-year difference in life expectancy between Maori and non-Maori, and chronic conditions accounted for somewhere between 70 and 80% of that difference. So if we could have an impact on chronic disease for the whole of our population, we would make a huge impact on life expectancy. We looked at demand, and we could see that all the projections showed the number of people with diabetes would double over the next 16 years, and renal failure requiring dialysis was increasing at a rate of about 10% per year. Anybody who's been to Counties Manakau will realise that Pacific populations and Maori populations have a frightening rate of obesity. And that was the elephant in the room, if you'll pardon the metaphor. BMI was increasing at a rate of 4.2% per annum. The population was ageing, so Maori and Pacific have got a young population, but over the next 20 years they would of course grow into middle age. And unless we did something about that, the rate of chronic disease that would exist at that time would kill the system. And when you put all these factors together, what this meant was we'd have to build a new hospital ward every 18 to 24 months to manage this rate of demand. And clearly, that was not the right thing to do, and nor could we afford it. Because one of the intricacies of the New Zealand system is that it's DHBs who need to fund their hospital builds. So that was a scary prospect. So what this meant was the Counties Manakau health system was under attack from chronic disease, and that's where our focus had to be. So what we decided to do was to act in a concerted and sustained fashion to try and make a difference to access and outcomes, and ultimately avoid the collapse of our health system under the weight of demand.